Today we'll talk about the infections and the glomerulonephritis. Remember, glomerulus is a highly vascular organ. 90% of the renal blood flow goes to the glomerulus. So infection doesn't cause glomerulonephritis directly, but infection can cause inflammation in the glomerulus by indirect means. And usually there are 4 or 5 types of the glomerulonephritis which basically are triggered by the infection. One of those is post-infectious glomerulonephritis that is triggered by infection. Second is the IgA nephropathy that is also triggered by the infection. Third is a C3 nephropathy, which is also triggered by the infection. Fourth is a cryoglobulinic glomerulonephritis, which can also be triggered by the infection. And the fifth type of the glomerulonephritic inflammation in reference to the infection is aggravation of an underlying disease. For example, infection can cause lupus flare-up. Infection can cause oncovasculitic flare-up. So these are the 5 main categories of the infection-related glomerulonephritis. So I will enumerate again: post-infectious glomerulonephritis, which was previously called as post-streptococcal glomerulonephritis. Second is IgA nephropathy, or also called as Berger's disease. Third is cryoglobulinemic vasculitis. Cryoglobulinemia can cause glomerulonephritis, and that is triggered mostly by the infection. And fourth is a C3 related glomerulonephritis, is also triggered by the infection, because infection can induce the production of the complement proteins, including C3. And fifth is a aggravation or flare-up of any known cause of glomerulonephritis. So we'll start with the post-infectious glomerulonephritis or the post-streptococcal glomerulonephritis first, and then we'll move on to the IgA nephropathy. Remember, the post-infectious glomerulonephritis, the word post means there's a delay. Post-infectious, after the infection. So usually the infection starts, and after a week or 2 weeks, this gap is important. Then the inflammation in the glomerulus starts, because the infectious antigen, they trigger the immune system, and the immune system takes 1 to 2 weeks to make antibodies. Then these antibodies will bind with the infectious antigen and make immune complexes, and those immune complexes deposits in the glomerulus to cause inflammation. So post-infectious glomerulonephritis is immune complex mediated glomerulonephritis. But remember, there is a delay from the onset of infection to the onset of glomerulonephritis or glomerular hematuria. This delay is at least a week or more, at least 1 or 2 weeks. If there is no delay, if the infection and the hematuria start on the same day or within a 24 hour, 48 hours, this is not going to be a post-infectious glomerulonephritis. This can be something else. However, this delay may not always be available, because sometimes the infection can be subclinical. If the infection is subclinical, then of course we cannot establish that there was a delay from the onset of infection, because we don't know when the infection actually started and to the onset of glomerulonephritis. So in case of subclinical infection, this delay is not there. Secondly, if the infection is recurrent and the body is already sensitized to that bug, for example, patient keep getting repeated sore throat with the streptococcus. So in those cases, this delay may be shortened, because the immune system is already prepared to start the inflammation. In the first exposure, the post-infectious glomerulonephritis always have a delay if the infection was clinical. Okay, and there are 2 exceptions to this rule. One is subclinical infection, when we don't know the onset of infection, so we can't establish there's a delay. And second is a recurrent infection, when the immune system is already sensitized. Now, important fact is this is immune complex mediated disease, so it can have the overlap with any other immune complex diseases, because all the immune complex diseases, they have few things in common. They will have immune complex deposition in the glomerulus. They involve the complement system, and the serum complement level should be low during the acute phase of the inflammation in the glomerulus. And when the inflammation resolves, the serum complement normalizes, and the biopsy will show the immune complexes. The deposition of the immune complexes in post-infectious glomerulonephritis is commonly in subepithelial location because the immune complexes are small in size, so they can traverse the capillary endothelium of the glomerulus. They can also travel through the basal membrane and they deposit between the basal membrane and the Bowman's podocytes, Bowman's epithelial cells, which is called the subepithelial space. Okay. Now, important concept is that because this is immune complex mediated inflammation and it involves the complement system, so inflammation is there and that can cause glomerular hematuria and due to the proliferative glomerulonephritis. Usually, there will be proliferation of the mesenterium and there will be proliferation of the capillary endothelium. Okay, and if the inflammation is very severe, as we discussed previously, it can cause proliferation of the Bowman cells and make crescents and can lead to crescenteric glomerulonephritis, also called as RPGN or rapidly progressive glomerulonephritis, which is usually seen only in 5 to 10% of the cases. Okay, so classically the post-infectious glomerulonephritis uh, is mild to moderate proliferation and inflammation of the mesenterium and the capillary endothelium. And classically, it spares the Bowman space. It rarely makes crescents. Crescent formation is only seen in 5 to 10% of the cases, in which case the disease is very severe. Okay. Now, any infection can cause post-infectious glomerulonephritis. Previously, it was labeled as post-streptococcal glomerulonephritis because first time it was described with reference to the strep pyogenes, which causes skin or the throat infections. This M protein of the streptococcus, which triggers the antibodies production against the M protein, and then this M protein makes immune complexes, deposits in the subepithelial location primarily, and causes inflammation and proliferative glomerulonephritis, leading to nephritic syndrome or glomerular hematuria. Right? However, any other infection other than streptococcus can also cause post-infectious glomerulonephritis. Just to name a few, staphylococcal infection anywhere in the body can also cause the same things. For example, patient has staph endocarditis and patient can get immune complex mediated post-infectious glomerulonephritis. Similarly, many of the viral infections can cause post-infectious glomerulonephritis, such as HIV, hepatitis B virus, hepatitis C virus, and any acute viral infections and other long-term viral infection, they can also trigger post-infectious glomerulonephritis. In the similar fashion, other infections such as malaria and even chronic infections such as TB and fungal infection, they can also trigger post-infectious glomerulonephritis. So any infection present in the body followed by the glomerular proliferative glomerulonephritis, if there's an appropriate delay and this is immune complex mediated with low serum complement levels and immune complex deposition in the kidney, is post-infectious glomerulonephritis. Now, there are some certain limitations and classic pattern of the post-infectious glomerulonephritis. I will narrate the classic pattern, and anything which doesn't fit in that classic pattern would mean either there's a post-infectious glomerulonephritis with some complication, or this is not a post-infectious glomerulonephritis and there's something else going on. For example, there's an infection, but there's no delay. Okay, so this is something else other than post-infectious because post-infectious glomerulonephritis has a delay of at least 1 to 2 weeks, which is needed for the immune system to be ready. Secondly, if there's no immune complex deposition in the kidney, even if there's infection, this is not going to be a post-infectious glomerulonephritis. Okay, so the immune complex deposition is very important to establish the diagnosis on biopsy. Thirdly, if the serum complement levels are normal during the active glomerulonephritis, this is not likely to be a pattern with the post-infectious glomerulonephritis. We need to think about some other differential diagnosis. Fourth, as I said, it classically involves the mesenterium and the capillary endothelium, and the crescent formation is rare. If the mesenterium and the capillary endothelium are not involved, but there are crescent formation, this is not post-infectious glomerulonephritis. This is probably ONCA or anti-GBM related glomerulonephritis. So crescent formation without mesangial inflammation and without capillary endothelial inflammation and proliferation is not post-infectious glomerulonephritis, even if there was an infection triggering the or initiating the process. Okay, post-infectious is mesangial and capillary, whereas the crescent formation is extremely rare and only seen in 5 to 10% of cases. That too in the presence of mesangial and capillary endothelial inflammation. And clinically, because it's classic post-infectious glomerulonephritis causes mild to moderate inflammation in the glomerulus. I'm talking about the classic one. So it causes glomerular hematuria, and usually the proteinuria is almost always subnephrotic. It almost rarely or never causes nephrotic range proteinuria. So if there's a presence of nephrotic range proteinuria, we need to think about either this is a complicated post-infectious glomerulonephritis or this is something else which which is mistaken as a post-infectious glomerulonephritis. And another important finding is the renal function, the disturbance in the urea and creatinine in a classic post-infectious glomerulonephritis is often mild to moderate. If there's a severe rise in the creatinine, for example, creatinine goes to 10 or 12, or if you're talking with the micromole unit, then 500 or 600, or the patient is heading toward the dialysis, there's a rapid onset renal failure, and the urea creatinine keep rising. So that is not common with the uncomplicated post-infectious glomerulonephritis. In those cases, we need to think about that this is probably a complicated post-infectious leading to RPGN or crescent formation, and right. And now, usually, the clinical course of all this disease is lost for 1 to 2 weeks. Once the infection is over, the glomerulus starts settling down. The inflammation in the glomerulus starts settling down within next 1 to 2 weeks. If it doesn't resolve within 2 weeks of treating the infection, for example, patient has a sore throat, we treat it with the antibiotic, and the glomerulonephritis doesn't resolve within the next 2 weeks after treating the antibiotic, this is not common with the post-infectious. It might be some either complicated underlying complication of the post-infectious, or is something else which was triggered by the infections. Okay. Now, when we talk about the resolution of the disease, remember the figure of 2. In 2 weeks, biochemistry and the clinical manifestation of the renal involvement, they usually settle down. For example, blood pressure will settle down, fluid overload should resolve, and urea creatinine should normalize within 2 weeks. In 2 months, 2 weeks, biochemistry and clinical manifestation, 2 months, the complement should normalize. And sometimes the proteinuria or hematuria can persist up to 2 years. So remember the figure of 2. 2 weeks for biochemical resolution, 2 months for complement resolution, and maximum 2 years for the proteinuria and hematuria to resolve. Why it takes 2 months or 2 years for the proteinuria and hematuria to resolve is because during the process of the inflammation, there is some structural damage to the glomerulus, and that structural damage is very slow to resolve through the regenerative process. That's why the proteinuria and sometimes the hematuria can continue for many months or maximum up to 2 years. If this pattern of resolution is not followed, for example, biochemical or clinical manifestation don't resolve within 2 weeks, or the complement level does not normalize within 2 months of treating the infection, or proteinuria and hematuria, they keep persisting or keep worsening rather than slowly tapering down, they keep persisting at the same level or they keep worsening, right, in the subsequent month. If we need to think about some other differential diagnosis, it was probably not a post-infectious glomerulonephritis. Okay. Most important thing in post-infectious glomerulonephritis, which you should understand by now, is when you should think this is not post-infectious glomerulonephritis. Okay. Right. Now, for example, if the patient has sore throat, we thought this is post-infectious glomerulonephritis. We treat it as post-infectious, but the complement level, even after 4, 5, 6 months, is still persistently low. So probably there is some additional disease which should explain this persistent low complement level. Similarly, persistence of the proteinuria and hematuria should also be a search for additional disease which can cause persistence of the proteinuria, hematuria, or it could be a complication such as a structural damage or a glomerulosclerosis. Okay. Similarly, if the infection is treated and the biochemistry, biochemical manifestations such as urea creatinine and the fluid overload, they don't resolve within 2 weeks, this is probably something additional or complication of the PAGN. Okay. All these variations of the typical pattern mean either this is not post-infectious glomerulonephritis, or if it's post-infectious, then it's complicated. Complicated with, such as with the crescent formation, or complicated with the glomerulosclerosis, or complicated with significant glomerular damage, or coexisting with some other cause of the glomerulonephritis, such as underlying undiagnosed lupus or undiagnosed oncovasculitis. Okay, so this is very important to understand what is the typical and of glomerular post-infectious. Typical is there's a delay, there's an immune complex deposition, there's a low serum complement level, it's a proliferation, mild to moderate proliferation, whereas crescent formation is only in 5 to 10% cases. Proteinuria is subnephrotic, and it resolves, biochemistry resolves within 2 weeks after the infection, complement resolves within 2 months after the infection, and proteinuria and hematuria, they should slowly taper down and they can last maximum up to 2 years. If any of these things is not fitting in the pattern, this is atypical. And this is where you need a biopsy. If the clinical presentation is typical, classic, everything is fitting in classic post-infectious, then we can avoid the renal biopsy and we treat it as a post-infectious glomerulonephritis. But if there's any atypical finding, then we need a renal biopsy to make sure we are not missing any additional cause or some alternative explanation for the patient's manifestation. Okay. The diagnostic workup, as I said, is clinical. There are two wings to it. One is diagnosing the underlying infection, because classically it's related to the streptococcus. So we do a anti-streptolysin antibodies, ASO titer, which should be 200, more than 200. Or we can also do anti-DNase antibodies, which are also specific for the streptococcus. And we can also do a throat swab. Throat swab is especially important, especially if once the infection is active. As long as the infection is active, there is bacteria in the throat. Okay. Presence of the active infection means the patient needs antibiotic for the infection. Treating the inflammation in the glomerulus depends upon the severity of the inflammation. If it's a mild to moderate disease and these manifestations are not severe, usually it should resolve with the treating the infection. But if treating the infection doesn't resolve the clinical manifestation, then we can use the steroids, corticosteroids such as prednisolone, to treat the glomerular inflammation. However, if there's a severe disease, such as there's a crescent formation and patient has RPGN, then we need to escalate the immunosuppression, such as methylprednisolone and cyclophosphamide. And in cases of RPGN, patient may need a plasma exchange. So treatment of the inflammation of the glomerulus depends upon the severity. Okay. Subnephrotic proteinuria may also need ACE inhibitors or ARBs to help with the proteinuria. Okay. Blood pressure can be managed with the with ACE inhibitor, ARB, or calcium channel blockers, right? And if those people who get recurrent infections with the streptococcus or with the same bacteria or same virus, they can be started with the prophylactic treatment as well. If the post-infectious glomerulonephritis is because of the chronic infection, such as hepatitis B virus or hepatitis C virus or tuberculosis or fungal infection, because the infection will take time to resolve, so usually the inflammation will keep going, and it will also be slow to resolve. In those cases, using the steroids to suppress the glomerular inflammation is more beneficial, because we can avoid the permanent glomerular damage. Any residual damage or any ongoing inflammation which is not treated can lead to glomerulosclerosis and can end up in the end stage renal disease. Although this is less common, but this is quite common in cases with the persistent inflammation or the recurrent post-infectious glomerulonephritis episodes, or if the infection is persistent. So that is about the post-infectious glomerulonephritis. Okay. Now, the second glomerulonephritis, which is triggered by the infection is IgA nephropathy. Remember, IgA nephropathy is a very important cause of glomerulonephritis, and it is very commonly confused with many of the other causes of proliferative glomerulonephritis. So remember, with IgA nephropathy, remember four A's. Four A's, okay? First A is airways and body lumens. IgA is normally produced by the lymphocytes, and its main purpose is to stay in the lumens of the body organs, where it acts as a protection against the infectious agents. Its main role is to prevent infections in the body lumens, such as nose, such as sinuses, such as throat, such as larynx, pharynx, trachea, bronchi, alveolar lumen, esophagus, intestine, bile duct, ureter, bladder, urethra, and genital lumens. Any lumen of the body organs has IgA. Okay, so A for airways and body lumens. So it is normally present in the body in the luminal organs of the body. When it's secreted from the lymphocyte, it comes in the blood and it's being thrown into the lumens, such as into the airways or in the GA tract or in the renal tract or in the urinary tract or in the genital system or in the bile duct. It is attached with the secretory protein, secretory component, and the purpose of attaching the secretory component with IgA is that so that it doesn't get reabsorbed back to the blood. Okay, so that is why it is tied with the secretory component. Now, because its main role is to protect against the infection is in the air in the body lumen, such as airways. It's like innate immune system, like neutrophils in the blood, which are ready to fight. So IgA is there in the body lumens ready to bind with the viruses or with the bacteria in the lumens. So whenever there's an infection or inflammation in the air in the body lumens of the body, such as CBD, such as ureter, such as genital lumen, such as renal tract lumen, such as the intestinal lumen, or such as the airways or the pharynx or nose or larynx, any luminal inflammation or infection increases the production of IgA. Okay, and if the patient has IgA nephropathy, it will lead to flare up of the IgA nephropathy. So remember, all luminal infections and inflammations, all infections of the body lumens and inflammations of the body lumens can trigger episodes of IgA nephropathy in patients who are known to have IgA nephropathy or who are at risk of IgA nephropathy. I'll come in a second. I'll come to the point who are at risk of IgA nephropathy. Okay, so all infections in the lumen, such as rhinosinusitis, pharyngitis, laryngitis, bronchitis, bronchiolitis, pneumonia, gastroenteritis, okay, right? Urinary tract infection, genital tract infection, cholangitis, they all can cause worsening of IgA nephropathy. If the patient is predisposed to IgA nephropathy or is at risk of having IgA nephropathy. Okay. Similarly, that was infection. Any inflammation of the body lumens, non-infectious inflammations will also produce more IgA. For example, patient has a celiac disease. Celiac disease is a protein-induced inflammation of the duodenum and jejunum. Because there's inflammation in the duodenum and jejunum, although it's not infection, it will produce more IgA. So celiac disease has association with IgA nephropathy. Similarly, inflammatory bowel disease is like Crohn's disease and ulcerative colitis, which cause ongoing inflammation in the intestine. It will cause, it can worsen or it can be linked with IgA nephropathy. Okay, for two reasons. One, whenever there's inflammation or infection in the body lumens, it will produce it. The immune system will produce more IgA. Number one. Also, because of the inflammation or the infection, the mucosal protection of the lumen is compromised. So it can lead to more reabsorption of the IgA. So these are the two factors how luminal inflammation or luminal infection can worsen IgA nephropathy. One, because of increased production by stimulating the immune system, because that's a physiological role of IgA to protect the body lumens. Second, because of the inflammation, the mucosal cells integrity is lost and the reabsorption of IgA increases. So IB, inflammatory bowel disease, celiac disease, interstitial lung disease, bronchiectasis, cystic fibrosis, pneumonias, okay, bronchitis, bronchiolitis, pharyngitis, rhinosinusitis, gastroenteritis, urinary tract infection, genital tract infections such as PID and cholangitis, etc. They all can be linked or they can trigger for IgA nephropathy. That is for first A, airways and lumens. Okay, this is very important to remember the role of the body lumens in case of IgA nephropathy. Secondly, antibodies are produced by the lymphocytes. So a malignancy of the lymphocytes, such as lymphoma, multiple myeloma, or chronic lymphocytic leukemia, it can produce more, it can produce any antibody. Cancer doesn't follow any physiology and it can produce anything. So just like myeloma can produce IgM or IgG, similarly, myeloma can also produce IgA as well. Similarly, CLL, chronic lymphocytic leukemia, and lymphoma can also produce IgA. So lymphoma patients or lymphocytic malignancy patients can also have IgA nephropathy, right? And IgA, which get reabsorbed from the body lumens, comes back into the blood, is normally cleared by the livers, okay, macrophages of the liver, the Kupffer cells of the liver. Now, if the liver is already damaged, now the clearance of the IgA will be reduced. Okay, for example, patient who have a diffuse liver damage due to liver cirrhosis, they can't clear the IgA, which normally get reabsorbed to a small fraction. So in these cases of the liver cirrhosis, they are also at high risk of IgA nephropathy. So remember the associations of IgA nephropathy. Second A includes luminal infections, which we have already enumerated. Luminal inflammation, such as IBD, inflammatory bowel disease, such as celiac disease, such as interstitial lung disease, cystic fibrosis, and bronchiectasis. Lymphomas and liver cirrhosis. These are the common associations of IgA nephropathy. Now, many patients have IBD or celiac disease or interstitial lung disease or pneumonia, but they don't get they don't have IgA nephropathy. Basically, it needs a genetically abnormal IgA. I'll come to that point. What does that mean? The third important thing which we need to remember about the IgA nephropathy. Third A, first A was airways and body lumen. Second A was associations, which is basically explained by the concept of body luminal infection and inflammation. The third A is A for Asians. Remember, IgA nephropathy is the most common glomerulonephritis in Asian population. In China's more than 50% cases of proliferative glomerulonephritis, they are because of IgA nephropathy. Okay, this is less common in Western and European countries, but it's still common even in West and Europe as well. But it's more common in the Asian countries. It might be some genetic predisposition, or we don't know the exact reason, but it's more common in the Asian countries. The fourth A we need to remember. First A was airways and body lumen. Second A is associations of the IgA nephropathy or the predisposing factor which can trigger or which can enhance the IgA nephropathy. The third A is for Asian, and fourth A is alternate complement system. IgA activates alternate complement system. Remember, there are two pathways for the complement system. One is a classical pathway, other is a alternate pathway. Classical pathway is the one which needs presence of antigen and antibody, full immune complex. Okay, if there's immune complex, that can activate the classical complement pathway. So usually we know that because the immune complex is made up of antigen and antibody, so by the time the antibodies they will be ready to be there, it will already be a week or 2 weeks. So our classical pathway is not immediately available to help the immune system. It's a very strong pathway, but it takes 7 to 10 days to be ready. Okay, whereas the alternate pathway can be triggered by, it doesn't require the presence of the antibodies or the immune complexes. It can be triggered by the bacterial antigens such as lipopolysaccharides of the gram-negative infections, It can be triggered by by IgA. It can be triggered by just antibodies or antigens. It doesn't need full-fledged immune complex formation, so it's ready to available. Okay, it's like a innate immune system, because IgA fights like neutrophils. Okay, in the body lumens, and it has strong link with the alternative pathway so that it can get help from the complement system. That's the basic reason why it activates the alternate pathway. Now the sequence of the classical pathway is complement 1 activates the complement 2, which activates the complement 4, 1, 2, 4. And then this complement 4 activates the complement 3. So 1, 2, 4, 3. This is the okay. The 4 and 3, they have changed their position in the counting. Complement 1, which activate complement 2, which activate complement 4, which activate complement 3, and then this complement 3 will activate this membrane attack complex from C5 to C9. Okay, this is a classical pathway which requires the immune complexes. Alternate pathway doesn't require 1, 2, and 4. It starts from complement 3. So 3 and then membrane attack complex. So that's why, because IgA nephropathy involves alternate complement pathway, C1 and C4 will be normal in IgA nephropathy. C3 may be low, but C1 and C4 will be normal because they are part of the classical pathway, 1, 2, and 4. Okay. Whereas alternate pathway start from C3. Okay. So IgA nephropathy, because it's mediated by the IgA and which activates the alternate complement system, the checking the serum complement level may be normal because of it doesn't affect 1, 2, and 4. Okay, so C1 and C4 will be normal, right? So this is important to understand that it. And when we do the renal biopsy, there are usually no immune complexes and there's no deposition of the C4, right? Now these are 4 A's. So A for airways and lumens, A for association with the luminal infections, lymphoma, and liver cirrhosis. A for Asian population has the highest prevalence of IgA nephropathy, and A for activation of alternate complement system, which means the renal biopsy doesn't manifest the presence of the C4 and C1 and doesn't have the immune complexes there in the renal biopsy. And serum level of C1 and C4 are also normal. Okay. Now, who are the people who get IgA nephropathy? Basically, these patients have one of the two genetic defects, genetic predisposition. Either there's a defect in the secretory component of the IgA. Normally, as we said in the beginning, that when IgA is produced, it is thrown into the lumen, and when it's thrown into the lumen, it produces it is attached with the secretory component, and the role of the secretory component is to keep it in the lumen. Otherwise, it can get reabsorbed. In these patients, the secretory component is often abnormal, and what that causes is that lead to the increased reabsorption of IgA from the body lumens back to the blood. So whenever there's infection, the more IgA is produced, more IgA goes into the lumen, and then it gets back into the blood, and it start depositing in the kidney. Okay. The second concept about the IgA nephropathy is normally each antibody has a light chain and a heavy chain, and there's a junction which is called as a hinge. At the level of the hinge, at the level of the junction, the IgA has a galactose which covers some part of it. So in these patients with IgA nephropathy, they have a genetic deficiency of galactose. It's called as galactose deficient IgA. Because of the galactose deficiency, the hinge part of the IgA gets exposed to the immune system, and the immune system may make antibodies against the IgA. So in this case, IgA will behave as antigen, and the immune system will identify this abnormal galactose deficient IgA as abnormal protein and will make antibodies against it, and that can also cause uh, IgA deposition in the glomerulus and start inflammation. All right. So this is why not everybody gets IgA nephropathy with throat infection or with gastroenteritis or with urinary tract infection or with cholangitis, but only those who are genetically predisposed with abnormal secretory component of IgA or galactose deficient IgA, right? Now, what actually happens? IgA, the main site of deposition of IgA in the glomerulus is the mesangium. Okay, so classically, it causes mild to moderate inflammation in the mesangium, and it spares capillary endothelium and it spares Bowman's capsule as well. This is a classic IgA nephropathy. So, classic IgA nephropathy is a mesangial deposition of IgA with inflammation of the mesangium and proliferation hypercellularity of the mesangium, but capillary endothelium is usually spared and Bowman cells are often spared and there's no crescent formation. This is classic. In severe cases, the disease can extend from the mesangium into the capillary endothelium as well, and it can lead to capillary endothelial proliferation. And even when the disease gets even further severe, then it can spill into the Bowman's capsule as well and can cause crescent formation. So severe cases of IgA nephropathy can have capillary endothelial proliferation as well, and in extreme cases, it can also cause crescent formation and RPGN like any other proliferative glomerulonephritis. But classic IgA nephropathy is usually a mesangial inflammation, mild to moderate mesangial inflammation. Okay, because it causes mild to moderate mesangial inflammation, and because of the inflammation, it ruptures some of the capillaries. So usually it causes glomerular hematuria. So the most common manifestation of IgA nephropathy is glomerular hematuria, right? In many cases, the glomerular hematuria is the only manifestation, and that is the without any other renal manifestation. Okay, but with the disease spreading to the adjacent parts of the glomerulus, it can also cause some proteinuria as well, which is usually subnephrotic. Okay, and mild to moderate derangement of the renal functions as well. In severe cases, when the capillary endothelium starts involving as well, it can cause severe renal failure. And in cases which make crescents, it can cause dialysis dependent renal failure or RPGN, rapidly progressive glomerulonephritis. Okay, but they are rare, right? Common and a typical pattern is mild to moderate mesangial inflammation with glomerular hematuria due to this inflammation, and either no abnormality in the renal function or mild to moderate abnormality. In severe cases, yes, they can cause further worsening of the renal function, proteinuria as well, and in extremely severe cases, crescent formation and RPGN. Remember, IgA nephropathy, when it's limited to the kidney, is called as Berger's disease. Berger, Berger's disease. Okay. There's a variant of IgA nephropathy which is called as Hennec-Schönlein-Purpura or HSP. HSP is or IgA vasculitis is basically a variant of IgA nephropathy which involve the capillaries outside the glomerulus as well. Okay, IgA nephropathy just involves the glomerulus, but HSP is a variant of IgA nephropathy, is IgA mediated disease, which involves systemic capillaries as well, such as skin, such as GI tract. So commonly it involves HSP. Remember P for pediatric age. HSP or Hennec-Schönlein-Purpura is a classic vasculitis of pediatric age group, usually around the age of 5. It's common in pediatric population. Secondly, second P is for purpura. Because it involves the capillaries and venules, it causes purpuras, especially in the gravity-dependent areas of such as buttocks and in the lower leg. So a child who they present with the purpura in the lower limbs, in the gravity-dependent areas, and because it HSP also involves the intestinal vessels as well, so it can cause bleeding in the ileum or in the wall of the ileum or in the lumen of the ileum. So because bleeding in the wall of the ileum will cause a swelling in the wall and the ileum can be pulled down into the cecum. So it causes ileocecal interception. So it causes acute small bowel obstruction. So usually these children they present with purpura in the lower legs or in the buttocks area, and they have abdominal pain and nausea, vomiting, and findings of small bowel obstruction due to the ileocecal interception. Okay, and they may have a glomerular hematuria as well. This is a classic manifestation of HSP. HSP can also involve other body organ, but classically it involves skin, the lower limbs, gravity-dependent skin. Second, it involves ileum, small bowel, and thirdly, it involves glomerulus. Okay. In addition, it can also involve other body organ, but it's a variant of IgA nephropathy. It's a systemic form. You can say this is a systemic form of IgA nephropathy. If IgA nephropathy just involve, if the IgA is related disease is just involving the glomerulus, mesangium, there's only the glomerulus, this IgA nephropathy. But if it's involving to skin and other body capillaries as well, then it's called as HSP or IgA vasculitis. For the diagnosis of IgA nephropathy, there are important things. Remember, we need two important findings in the biopsy. Number one, there should be IgA deposition in the mesangium of the kidney. Okay, and plus there should be inflammation and proliferation of the mesangium. Just presence of IgA in the mesangium is not diagnostic for IgA nephropathy. Many patients who has proteinuria, they also leak IgA and they may have a IgA deposition in the mesangium. For example, diabetic patients with nephrotic syndrome may have IgA deposition. Similarly, a myeloid patient can have IgA deposition in the mesangium. So just the presence of IgA alone without inflammation and mesangial proliferation doesn't mean this is IgA nephropathy. Similarly, mesangial inflammation without IgA mesangial inflammation without IgA also doesn't mean this is IgA nephropathy. So there has to be two components. One, there should be IgA deposition in the mesangium along with C3 and mesangial proliferation. Both these factors should be there to establish the diagnosis of IgA nephropathy. Otherwise, just presence of IgA is doesn't establish the diagnosis. Similarly, absence of IgA also exclude the diagnosis of IgA nephropathy. So if there's no IgA deposition in the mesangium, this is not IgA nephropathy. If there's just IgA deposition without inflammation, this is also not IgA nephropathy. For example, patient has glomerular hematuria. Patient went for the renal biopsy. The biopsy shows there's IgA deposition in the mesangium, but there's a crescent formation. There's no inflammation in the mesangium. So this IgA deposition in this case is not IgA nephropathy. This is a bystander. This is not IgA glomerulonephritis and nephropathy. This is basically a crescenteric glomerulonephritis due to oncovasculitis. So if this, again I'm repeating this is a very important fact. There should be IgA deposition in the mesangium, number one. Number two, there should be inflammation of the mesangium. Okay, inflammation and proliferation of the mesangium, right? Then it's IgA nephropathy, right? But if there's IgA deposition in the mesangium, but there's no inflammation in the mesangium, instead there is a crescent formation, this is not IgA nephropathy. IgA nephropathy starts from the mesangium. We cannot diagnose IgA nephropathy if there's no mesangial inflammation and if there's no mesangial IgA deposition. Both of these factors are essential for diagnosis. Okay, just presence of one in the absence of the other factor exclude the IgA nephropathy, and we should think about something else, right? Now, how do we treat it? The serum level of the IgA may or may not be high, depending upon, because of course when the IgA comes more in the blood, the liver starts hyperfunctioning to clear it, and also because of the deposition, the plasma level may not be high enough to be detected by the lab. So serum level may not always be high, but renal deposition is essential for diagnosis. And serum complement level C1 and C4, they're normal. Okay. Any variation in these patterns, for example, inflammation in the glomerulus but not in the mesangium, this is not IgA nephropathy. Lack of deposition of IgA in the mesangium, this is not IgA nephropathy. Crescent formations or capillary endothelial proliferation without mesangial inflammation, this is not IgA nephropathy. Okay, right? Now, that's about the diagnostic clues. Another important concept to be understood is, remember the first lecture in the glomerulus, we started with this sentence that glomerulus is a bunch of capillaries. Now each capillary, if you look at the circumference of each capillary, roughly a two-third of each capillary in circumference in circle is covered by the Bowman cells, and one-third of each capillary is covered by the mesenterium. Okay, that means the mesenterium, as the border of the mesenterium, they are touching the Bowman's border there. Okay, now the inflammation in the mesenterium can trickle down into the Bowman's epithelium and can efface the food processes. So IgA nephropathy can be associated with minimal change disease. Okay, I'll just make it just to show you what do I mean. This is endothelium. Uh, I'm just drawing it. I'll show you in a second. These are the food processes. And this is the blue is a mesenterium. Now, if you look at this diagram, this is what I'm referring to. Okay. This is the mesenterium, and this red is capillary, and these are the podocytes, the green one. And in IgA nephropathy, the inflammation is here, and it can easily trickle down to this point and can efface the food processes. Okay, this is what I meant. So IgA nephropathy can also be associated with minimal change disease, which is basically effacement of the food processes. Okay. Now, how do we treat IgA nephropathy? Basically, it depends upon the severity of the disease. If there's just glomerular hematuria with everything else is normal, there's no proteinuria, there's renal functions are normal, this doesn't have fluid overload or hypertension or any other manifestation of the kidney disease, it's just a glomerular hematuria which is asymptomatic otherwise, discovered incidentally or and the urine assessment, patient usually doesn't need treatment. However, if there's anything additional to the glomerular hematuria, for example, patient has a subnephrotic proteinuria, or patient has a full range of nephrotic syndrome as a proteinuria, all right, or the patient has involvement of the capillary endothelial inflammation or the crescent formation affecting the renal functions. So IgA nephropathy with glomerular hematuria plus anything else in addition to the glomerular hematuria, such as rising urea and creatinine, such as fluid retention, hypertension, proteinuria, either subnephrotic or nephrotic range, okay, or the biopsy showing inflammation of the capillary endothelial involvement or Bowman capsule involvement, right? All these cases, which are more than just the glomerular hematuria, they need immunosuppressive therapy, all right? The proteinuria in IgA nephropathy can be managed with ACE inhibitor ARBs and prednisolone, oral corticosteroids. The severe inflammation in the glomerulus or the crescent formations, they are treated as oncovasculitis, which means the patient will need aggressive immunosuppressive therapy such as methylprednisolone and cyclophosphamide. And if in severe cases, patient may need a plasma exchange as well. So that is about the treatment of IgA nephropathy. Basically depends upon is there anything else in addition to the glomerular hematuria. Just glomerular hematuria alone doesn't need any treatment, okay, which is incidentally discovered. But presence of abnormal renal functions, presence of proteinuria, or presence of inflammation in the glomerulus, which is extended to the capillary endothelium or to the Bowman's capsule in the form of crescent formations, that definitely needs immunosuppressive therapy. The severity is the factor which determine what immunosuppressive therapy is needed. If it's just mild to moderate proteinuria, oral prednisolone or ACE inhibitor ARB may be enough. But if there's a severe inflammation of the capillary endothelium or the crescent formation, patient need treatment like oncovasculitis. All right, so we'll stop here.